Hello.
Hi, Arvind. Very good morning.
Good morning. Very good morning, Ji. Very good morning to everyone.
So you are in Madurai.
Yeah, I'm in Madurai.
I think she's dead. She's telling Rama they will be starting now.
Okay, thank you. Thank you very much.
Hi, Dr. Rakesh. How are you?
I'm very good, Dr. Neeraj. So nice to see you.
Yes, happy.
Good morning, doctor.
Yeah.
Good morning, doctor.
Dr. Ashwini, how are you?
I'm fine, Dr. Neeraj. Good morning, sir. Verma, sir.
Morning,
Good
morning.
Yeah.
Dr. Abhijit, Dr. Jankna, good morning.
Yeah, good morning, everyone.
Yeah.
Good morning, Dr. Verma.
Good morning. Morning. So, Remaji, can we begin? Okay.
Sir, Sakshi is here to give the introduction and then we'll start.
Yes.
So good morning, everyone. I, Sakshi Singhal, on behalf of QAI, welcome you all. We are celebrating World Patient Safety Day 2023 with a webinar. We have gathered here QAI assessors and clients to hit on the theme, engaging patients for safety. So thank you everyone for joining. We have with us Dr. Rakesh Verma, CEO, Aeon Med New Delhi, session moderator for today. So I request Dr. Rakesh Verma to kindly give welcome note and throw light on the slogan for the year 2023, Elevate the Voice of Patients. Thank you.
So good morning, everyone. I hope my voice is audible. And at the outset, I think the Quality and Accreditation Institute has taken a beautiful step of touching an aspect of patient safety, which has not been touched by anyone. I have been in this field of quality and accreditation since 2007. And like many of you would also be in the same field for a long time. This is one subject that touches all of us. And yet we look at this subject like six blind men looking at the elephant. So we all talk about parts of the problem, but we somehow are unable to see those parts which towards which we are, blind, whether by design or by default. So it's a beautiful initiative. It's a new perspective as to how patient safety can be looked from a perspective of an assessor, because as an accreditation body, we are involved in assessment of hospitals for accreditation purposes, where the quality and safety, both pillars have to exist, have to coexist, and have to, sorry. So both these pillars have to be there, substantially be present, so that the quality and safety is achieved. Now, patient and family engagement has been a theme that is not new. It has been there all along, and every patient safety literature that we see, whether in textbooks or in any of these forums or medias, including what is given by World Health Organization, patient safety has patient and family engagement as the core strategies. However, how we have been able to address it so far is something that desires, or that leaves a lot to be desired. So impact of meaningful patient engagement is significant. Why? Because there are studies to show that up to 15% of burden of harm can be reduced simply by engaging patients. And this is not data that has come from what I'm saying. This is given by WHO. There are studies to prove that engagement with patient improves every aspect of patient safety, whether it is fall prevention or whether it is medication safety or many other issues. So with this little, what this understanding has done is that the World Health Assembly's resolution and also the Global Patient Safety Action Plan for 2020 and to 2030 includes the patient engagement as the fundamental principle. And that is the reason this year's theme for World Patient Safety Day is engaging patients for patient safety. And World Health Organization has given a beautiful slogan for this purpose: elevate the voice of patients. We all hear the voices of patients, but how do we hear them? We hear them as markers to the symptoms, as markers to the signs, but we do not hear the voice as marker to patient safety. I think this is something where elevating the patient's voice has a role to play. Now, I'm reminded of a small cartoon that was floating on Twitter a couple of weeks back. So it's just a snapshot of a conversation between a doctor and a patient. And the doctor is telling the patient that don't tell me about what you have discovered about your disease from Google. So don't show off your Google knowledge. So the patient retorts and says, doctor, you don't confuse your 1 hour of lecture on my condition with 20 years of my living with that condition. I think this is something that points that the patient's perspective is so very significant. Our understanding, when we look at a patient, we look at a patient from a perspective where we want to help and treat. However, this endeavor itself requires engagement of the patient. So, so what are the objectives? Why are we sitting here today to talk about it? So the defined objectives, what have been given by the World Health Organization, are raising global awareness. And I think we are doing it in our very unique way of looking at the perspective of the assessors who are responsible for assessing the hospitals from the perspective of patient safety. And we are also going to look at the perspective from the clients, the hospitals. When we say client, we are meaning the client for the accreditation bodies. So the hospital's perspective. So these two perspectives are important, and raising awareness among all stakeholders is something that is very, very important. Engaging policymakers, I think there are enough endeavors at every level. Government of India also has had, there is National Patient Safety Initiative and many other things. But like every uncoordinated activity, this also remains a flash in the pan. So an event happens and something happens, and then we all go back to what we were doing before that. So these objectives are important. So raising the awareness, engaging with the policymakers and all stakeholders, empowering patients. Now, we all have seen quality systems, JCI, NABH, QAI, and NQAS. Everybody talks about patients' rights, patients' responsibilities. Are we empowering them enough? Having seen accreditation for 15 years, even today, our consent forms are signed by whom? By patients' family members? And who gets them signed? It is the nurse in the ward who gets this signed. Are we engaging the patient in a manner which makes this very important conversation about the disease, about the management, which happens as a part of consenting process? So we are still a distance to go. And finally, one of the objectives is to advocate what action that can be done. So let us see what we discover from our deliberations today. And we have a panelist. I'm sure all of you have seen the agenda for the program today. So we have panelists, and we will go by the topic that have been assigned for various groups of, or rather pairs of assessors and the client speakers. So I'll begin with Dr. Neeraj Lal and Dr. Arvind Sharma. And this is with specific reference to Remaji, there are some comments saying that the voice is not clear. So can you just have a look at it?
Yes.
So this topic deals with advocating urgent action on patient and family engagement in case of stroke. Now, stroke we know is an emergency, and of course, all of us treat it as an emergency. But how much is our understanding as to the promptness, the way the stroke will then be addressed? Half the time, patients goes all over the hospitals. He will visit multiple hospitals, and finally he lands up in a proper center, having lost significant amount of crucial initial 1 hour or 30 minutes or 40 minutes. And that is where we need to understand what advocacy can be done for initiating urgent action on part of the patients, and how does this impact patient safety. So I'll begin asking Mr. Neeraj Lal to throw a light from the perspective of an assessor, and thereafter Dr. Arvind Sharma, please enlighten us on how as a client, as a hospital, we could do this.
Thank you so much, Dr. Verma. I think we have launched standards for stroke, advanced and primary healthcare just 1 year back, and we have audited around 4-5 centers. I think stroke is truly a situation where every second and every minute counts. So I think with that aim in mind, QI have launched these standards. I'll talk about now from the patient side. I think Dr. Arvind will talk about from the hospital side. So what I feel, there is a standard PRE which clearly state the center educate the patient and family to make informed decision and their involvement in the care planning. So I feel, timely recognition and response is very, very important. I think there was a study which was done which talk about the patient who recognized stroke symptoms and sought medical help within 3 hours have significantly better recovery rates. So it shows that. Secondly, adherence to the medication and rehab. So it has been seen patient adherence rates increase by 20% in one trial. Like less than 25% of stroke caregiver are currently involved in patient rehabilitation goal setting. So that is the second part of it. Third is emotional support. I think stroke is a global disease. A support group for stroke survivor and the family. It has been seen there is a reduction in 30% reported depressive symptoms. So these are the things which is required for the significance for the patient and family engagement and the strategies. I think education is very, very important. We as hospitals, I think we are not spending time in educating the patient's relatives. So educational campaign across community, it has led to 15% increase in the percentage of stroke patient arriving at the hospital. So you can thought if there is no awareness among community, if we increase the community awareness, there was a study which was talking about 15% increase in the patients arriving at the hospital. And communication, I think communication, because of now we got so many medium. So I think reduce communication related error by 40% in the hospital stroke shown it. And I think one most important thing which is happening after COVID specifically, the technology part of it. I think telehealth and mobile app, it enhances the accessibility to the healthcare resources. And there was an example which you were saying, tele rehab program have shown 30% increase in the patient engagement and adherence to the therapy pain. So over to you, Dr. Arvind, as a stroke specialist, about your comments.
Thank you, Neeraj. I'm audible, right?
Yeah.
I'm audible. Yeah. Thank you, Neeraj. Thank you very much for about the patient engagement and the safety of the patient. The deliberation you have given about the stroke. I will thank QI for inviting me as a stroke specialist here, and thank the moderator, Dr. Rakesh, for giving us this opportunity. Stroke, if you see, is a teamwork. You cannot do it alone. So when you see, there are a lot of studies which Dr. Neeraj has spoken about, but I would like to tell you about one study which is very important.
You're in a muted mode, Dr. Arvind. We have yeah.
Audible?
Yeah, it's fine.
So I'll talk to you. Yeah, I'll talk to you about one of the study about the West and what the Indian settings are having. If we take in the West, as the patient is discharged, it goes to the assisted living. You know, stroke is a very disabling disease where you're not able to walk, not able to sometimes speak or communicate. So there, the patient engagement and the family engagement for the safety is very important. And as you're talking about the neuro rehabilitation and the improvement of the patient after stroke is much better in the assist study in India rather than in the West, where the assisted living is done by the nursing care and the hospitals. But in India, it was seen when the care was given by the family members and taken care by the family members, their swallowing came much better. They walked very fast, and a lot of positive things happen in stroke when the patient and the family were engaged and addressed about the care, that what to be done. I will talk about 2 3 things in that. About the stroke patient have, when they have stroke, they have a swallowing difficulty. I'll talk about the technical aspect, but this is very important on the patient and the family engagement, right? So when they have a swallowing difficulty, they have to be on the feeding tube that is known as the Riles tube to be done. So if that part is done by the family member and they are understand how to do it, we a lot of aspirations, the pulmonary aspiration, lung aspirations are being avoided. The second thing, the nursing care, which is done by the family members, because they are doing the physiotherapy also for the patient, for their family member, it makes a lot of emotional touch, which was Neeraj was talking about, that their family members are taking care of. There is more will to get all right in the patient. And third is the fall, which we should take care in the stroke patient. And if the family members and the patient are addressed when they go to the home, go to their home, and they are disabled at that time, they should be let them understand about that safety, which is very important. But if you don't address this issue when the patient is discharged and patient is in the hospital and you don't engage the family members, the outcome is worse. It's been seen, even done in the West by the trained nursing staffs and by the doctors, but it is much better when the family members are engaged in the patient care and the safety. Thank you very much.
See, I must comment Dr. Arvind. He is in a conference in Madurai, IonCon 23 in Madurai. He's attending, where I think around 1,000 neurologists across the country is participating. And thank you for taking time out and participating. That shows we care about patients and their relatives.
Thank you. Thank you for getting me on board.
Thank you, Dr. Arvind and Mr. Neeraj. Important perspectives. I think in the quality system, when we do the assessment, when we go to do the assessment, it is important to look for evidence of patient engagement. How do we do that? We have standards. There are stroke center standards which talk about what should be the patient education, what should be the consent process. However, as an assessor, when we go, how do we verify that the intent of the standard has been implemented? Now, it is one thing to say that we have a form and somebody fills that form and that form is completed and put in the file. The other part is how the intent is completed. I think this is one aspect where we'll need to focus, because once we look at the intent and try to implement it, the patient engagement is almost a natural flow. It flows from there. The moment we look at the intent, and then we will talk to the patient and we will understand his side of the story, and therefore the engagement becomes better and also the outcomes become better. So we go to the next topic for today, and this is about the assisted reproductive techniques, the IVF centers, where the client's willingness to educate the patient and engage the patient in the entire process is critical. It is critical because a patient is, comes to an IVF center with a very different mindset. It is not a patient who is unwell, who is unwell in the classical sense of like a stroke patient who is unwell. But here a patient comes for a very different requirement. how do we ensure engagement of patient? How do we ensure that patient understands the nuances of what he or she is getting into this? So we have Dr. Amol Pawar and Dr. Sarvana Kumar, who will be talking about two different aspects. One about the IVF and ART, and Dr. Sarvana Kumar will be talking about the emergency department. Now, engaging patient or engaging with the patient in emergency department is a different game altogether. The situation is different. The patient comes with an emergency, which is an emergency in the mind of a patient. For a doctor, it may or may not be an emergency. And then how do we do that engagement process? So let us hear from these two stalwarts. Dr. Amol Pawar is additional professor from Nauroji Wadia Maternity Hospital in Mumbai. And Dr. Sarvana Kumar is the GM and unit head, consultant emergency medicine at Dr. Mehta's multi-specialty hospital in Chennai. Both hospitals accredited under AQI standards, QI respective standards, the IVF standards and the emergency department standards. Dr. Amol, is he online? I don't see him. Remaji, can you just put a call to him? In the meanwhile, let us
Dr. Amol just sent me a message that he won't be able to join as he has some urgent patient to attend.
Let us hear, okay, so let us hear from Dr. Sarvana Kumar. How do we engage? How do we engage with patient in emergency settings? What is different in emergency setting that does not happen elsewhere? Dr. Sarvana.
Thank you, Dr. Rakesh, and for giving me this opportunity. And so I'm very happy to be here. I am an emergency medicine specialist myself. And as you rightly mentioned, sir, we are the first institution in India to get a department-specific accreditation through QI in our hospital at Dr. Mehta hospitals. So thanks for giving this opportunity to speak something about the patient, engaging patients in patient safety in ED. Interestingly, the patient safety issues in ED, as you know, ED has got broadly two groups of patients, one who are really sick and one who are elective, or I would say reasonably stable patients. But what's interesting to note is there are much more higher risk of these patients who are stable to have patient safety issues compared to somebody actually sick or those priority 1 patients. I'll tell you how, because anybody who is quite sick or priority 1 obviously has a better attention. And anybody who is reasonably stable, the attention level actually goes down in ED. So let me give an example. So let's take pediatrics. It's one of the common areas in ED, where there are two common issues. For example, a child comes for evaluation, say for a fever or a seizure, for even a simple illness, right, where we keep them on an ER trolley. And the most common problem in an emergency department is the child falling from the ED beds, right? Because we either forget to put the side railings, or typically in an emergency department, we don't have facility for even the patient's attenders to be engaged to stand right next to the child, because there's no chair or a place to stand or sit, right? So especially in pediatrics, it's challenging to engage the patient's relatives, but we need to do that as well. So one of the implementations we have done in our institution is clearly we had small stools placed right next to each of those beds so that the mother or a parent can sit right next to the child. So it's not only the side railings, but we need to engage them, because all the standard side railings from all those beds are made for adults. So children can still go through that gap between those side railings and fall. So these are small nuances we need to note, especially when we go for assessment to see how do this institution has engaged in providing patient safety for children. The second example I can say again in pediatrics is clearly when we prescribe medicines when somebody is going home from emergency department, right? We tend to prescribe medicines, and medication safety is an issue because the dosages come in different forms. Simple paracetamol can come in 250 mg in 5 ml and 500 mg in 5 ml. So when you prescribe a dose for the body weight, we prescribe it assuming the child is going to get a 250 mg per ml, 5 ml dose, right? And we often end up seeing patients coming back with paracetamol overdose, unfortunately, right? So these are medication errors which are extremely common, and this is where we need to engage the patient's relatives in a way where we can actually brief them on what is the actual dosage in the medicine they need to look for. If possible, have a mechanism to perhaps show the medicine before they even go home, right, when they purchase from the pharmacy. So we need to look at the ways for how are we looking at the medication safety. Reconciliation is another problem, especially because patients don't bring with their previous files or past data most of the times. So when you admit somebody, so you are looking, or you're extremely focused on the current emergency situation, but then you are not looking at what were the previous medications somebody has been taking for a longer time. Very simply, the hypertensive medications, diabetic medications, antipsychotic medications, all those cannot be stopped, but there is no focus that on medication reconciliation. That's one area which goes very commonly wrong in ED, where we are focused on the emergency situation, admit the patient to IP, but you have forgotten to look into the previous medications, and only 2 days or 3 days later, so you're realizing that these are past medications somebody has been taking and that's been missed for 2 or 3 days. I think these are the few common areas which we can see in an ED. And sir, as you mentioned, as an assessor, what do we look for, especially when you go for an assessment, and how do we ensure that they've been actively engaged? Is clearly I can see what sort of a discharge advice people are getting from ED. Is there a mechanism where they give either a return or a printed discharge sheets to attenders, so that that's one area which we can look at, and also look at some of those simple structural facilities, like what sort of a ED bed they use, what sort of a side railing they use, is there a facility for somebody to accompany the patient, sit along with the patient, and things like that. And also consent practices, especially in an elective situation. Emergency situation, obviously you might not need a consent to provide those ABC stabilization, whereas in the elective, look at how they're engaging the patient, attenders or relatives or patients themselves, so that we can perhaps review some of those consent forms. So I think I'll stop with this and pass it back to you, sir. Thank you so much.
So very good insight, beautiful insight, Dr. Sarvana Kumar. I think we should be in a position to review our emergency patient flow. When we say emergency patient flow, our primary objective is to put the patient through the process as quickly as possible. Why? Because we think it's an emergency, which is right. However, how do we do this? So we have elaborate systems for fast tracking the patient. So you don't bother about registration. You put the patient into the triage process, and then you rush the patient through the patient care steps. But have we ever wondered, are we having any a pause to engage with the patient in this entire rushing through? I mean, as such, the hospital processes are fast tracked as far as patients are concerned. I mean, from a perspective of a patient, even an elective procedure is actually a fast tracked procedure. It's happening, everything is happening too quickly. And now in emergency, we specially designed systems so that they are super fast. Why? Because the basic understanding is that there will be we need to save time. However, are we allowing engagement to happen in those processes? In that fast track processes, what is our view? How do we implement patient engagement in that? After all, whether a process is fast tracked or not fast tracked, patient engagement remains to be a primary requirement. We can't say that we have fast tracked the process and forgotten the patient engagement. So therefore, I think this is one perspective which we have possibly not looked at so well. So this is one food for thought I thought I should mention. Sorry, I'm just recovering from a viral fever, so my cough is coming as a interference in the process. So let us move forward while we will get back to Dr. Amol when he's free from the emergency that he's handling in his hospital. Moving on to the home care and transition care standards. Now, QAI was the first organization that came up with the home care standards, followed by transition care standards, and how these standards are supporting the engagement of patient. So we have Ms. Usha Prabhakar, who is the Regional Director, Nursing, Apollo Hospitals, Hyderabad. Dr. Tarini Singhal, who is the Quality Head, Portia Medical, and Dr. Zankhana Boch, Chief Medical Officer, Ayurved Hospital, Bangalore. Dr. Zankhana, I hope I have pronounced your name correctly.
Yes, you have pronounced it correctly, Dr. Anish.
Thank you. So these are few patient care settings, home care, transition care, where I mean, these were invisible to us. I mean, some of us were aware, but not. I can all confidently say that not everybody in the health system was aware that even the home care and the transition care is something that needs to have standards and needs to perform in a certain manner. So therefore, these standards are helping. Our perspective today is to understand how the patient engagement will happen. How do we elevate the voice of patient in a home care setting? I mean, it's very peculiar. The patient is at home. There is just one or two providers which are there from the organization which is providing care. How are we doing this? So let us understand. Ms. Usha Prabhakar is there?
Yes, please. I'm there, but unable to switch on my camera. Please pardon me for that, but I'm there.
No problem, ma'am.
Thank
So
you.
you're actually, because the camera was not on, so you're I mean, you're not visible. You're on the second page of the of the people on the screen.
Yeah, no problem.
So can I request you to throw some light? How do we do patient engagement in these two settings?
Yeah. Thank you so much, first of all, for giving me an opportunity to speak up about Dr. Rakesh and Dr. Rana for inviting me. Thank you so much, and the other co-speakers. Let's start with the slogan. Whether it is a home care or assisted care homes or in hospital, we all are healthcare team, and it is representing as a one team, one healthcare team, and we all are having one dream, and that is excellency in patient safety. So on this International Patient Safety Day, two things we would like to talk about it. One is when we are onboarding a patient, discharging from the hospital to home or assisted care home, how does that safety happens in terms of complete transition from the hospital to home? That is one safety parameter where engaging the patients and the carers are very, very utmost important. And number two aspect is after settling down at home, what are the 4-5 things when the care assistant care being provided at home? The safety in terms of everybody talked about it before also regarding the medication safety, the safe injection practices, because nobody is there to watch at home. Unlike like a hospital setup. So there is a one employee or one carer who is looking after the patient. So how does that safe injection practice happens at home? And number three is the healthcare associated infections. We all talk about it, but when it comes to long-term stroke also we have discussed just now. So the catheter, if it is there, how does that UTIs can be prevented? Number three. And number four is injuries at home also are very, very highly, we have seen the data talking about fall at home and developing a pressure sores at home. And Ryle's tube aspiration, if there is especially a patient who is discharged and risk at home. And the last one is regarding the, along with the fall, there is a sharp safety as well, where the patients and carers injecting themselves the insulin self-administration. How does that safety of the sharps can be maintained at home? Yeah, am I audible? Sorry. Yeah. Okay. So these are the few aspects. So the first thing is hello.
Yes, you're back, ma'am.
Yeah, sorry, yeah. So quickly we'll discuss about the solutions now. How does the patient family have been engaged, and how do we listen to the voice because they're at home, scattered across in cities? How does that their voice reaching out to the proper centers? So number one is medication safety. We'll discuss medication safety. The nurses or the whoever doctors, whoever is administering, we have to involve patient and carers regarding taking okay by explaining the why we are giving the medication, what is the actions and what is the complications, so that
Ma'am, your audio is not there. I think. There is an interruption because of the network issues. So let us not disrupt the program. Can I ask Dr. Tarini Singhal? Dr. Tarini, can you hear us? Okay. Remaji, please look at that. So we come to Dr. Kankhana Bhuj. Ma'am, are you back?
Hello. Yes,
Sorry, I'm back. Yeah.
Am I audible?
The Dr. Tarini, please wait. There was an interruption, and because of that, I thought we can move on. But Ms. Usha Prabhakar is here. So, madam, please complete your point.
Yeah. Sorry. So number 2, regarding the feeding, the involvement is not only the nurses or the carers at home while handling the feeding. The tube placement is very, very important. So we have to mark the tube so that the tube is pulled out or it can be noticed by everybody. The tube placement is very, very important before giving the feed. As the auditors, when we are going at home, we are understanding and evaluating that whether the feeding is in place, but feeding tube placement, whether the carers are aware about or not. Regarding the skin, even like in hospital, the post-stroke or the bedridden or end-of-life care packages, when we are taking it and providing the care at home, or the special bed or the special mattresses at home, the skin care is being highlighted. The patient and family aware about the changing the position and preventing the sore at home is also very important at the time of onboarding itself. And also, when we have seen many patients who are discharged from the hospital with a grade 4, grade 3 sores. So how does the dressing happen? How does the infection prevention protocols at home is being maintained in order to improve as well as to prevent in regards to the skin care? Feeding, I think when I was talking, it got disconnected. So feeding, I've talked about it. Skin care, I talked about it. Medication safety, in regard to the insulin, we have seen. So there should be information brochures. No need of now paper cost. Now everything is a digital media. Digital media can be used, all these providers to provide the insulin injection in regards to the administration, in regards to the storage, in regards to the hypoglycemia management and identification. That is how we have to advocate and involve patient and carers while especially administering this insulin types of it in regard to the medication safety. Catheter care is one when we have seen long-term catheters have been introduced and discharged. At that time, the care, the clinical skills of the nurses have to be utmost, along with the infection control protocols, and then how do we hang, how do we identify early urinary tract infections, and escalation metrics is very, very important. It can be escalated through the patient care as well when they are awake. So we have to provide information. How do you early recognize the UTIs and how do you escalate so that the doctor visit can be arranged and looked into it. And the sharp safety at home also, when we are, so sharps needs to be discarded properly. So the sharp containers needs to be provided so that, and then the last one is a fall. We have seen many post-stroke rehabilitation while it is happening at home, or even the patients who are not fully independent or the elderly care. In that time, when we are going as auditors, we'll go and see assessors, especially into the washrooms, whether the side bar is really required, it is there or not, if it is elderly care or the unsteady limbs. And also the anti-skip mats are being, we can advise, we can provide, we can engage them that how much is the importance of the fall prevention at home along with the safety devices. And the last one is, injuries due to the medical devices is also been noticed. A lot of data is there in international UK and the US. Since I worked in UK and I've seen it. So many injuries due to especially nebulizers, oxygen cylinders. What is the backup mechanism? How does the pressure and to maintain the different kind of equipments which we use it. Even we have seen BiPAP, night BiPAP, CPAP, many patients use it. So how do we operate? How does the alarm setting happens? Is also patient and family needs to be advocated and information to be given along with the healthcare providers. These are the different aspects which we need to see and provide and use the digital media in terms of engaging patients and carers in terms of the patient safety. Thanks so much.
So, Ms. Usha Prabhakar, thank you very much. Very detailed view. I would only say that we have in most home care settings, because of the standards now, we have an elaborate process of onboarding the patient. I think we should have a very elaborate process of onboarding the family members as well. That is where the engagement will happen. Our accreditation assessment should look at not only the onboarding of patient, but also the onboarding of the family, because it will always be the family that will be the center point for all care issues. Dr. Tarini Singhal, can I bring you in here? You are the quality head of Portia Medical. How do we address this patient engagement in home care setting?
Thank you, sir, for giving me this opportunity to speak in this forum. Well, in Portia Medical, we are having a very active patient engagement activity, wherein not just our healthcare workers are getting involved with the patient care or patient safety while being at home, providing them the medical facility in terms of services and equipments, but we also have our senior management also intervene directly face-to-face with our patient interface. So as part of this entire activity, as part of this initiative, we, including me, we have visited few patients' home and have been on the front end of seeing the treatment quality, seeing the patient involvement, patient family members involvement, and which is also part of our feedback mechanism and part of our directly seeing the service quality. So in terms of be it our nursing services or nursing attendant services or any equipment or pharma, we directly get involved with the patient party. And also as an interaction when it happens with patient attendants, we get to know what are the shortcomings they have faced, or what are the high level of expectations they have, so that we can also think about it and in terms of process change or policy change, or our way of monitoring patient care that we do as part of a quality improvement program. So that has bring a lot of enlightenment and lot of scope of improvement that has come to us. And not just that, but the patient satisfaction has also moved to a higher level. So patients are very much engaged with us now as compared to the previous process that we were following. We were settling up things, we were trying to bring awareness, but this initiative has brought a lot of confidence in our patients as well as our staff. So that's about it, sir.
Thank you, but I would want to ask you, is there a structured process for the patient and family engagement as part of onboarding for a home care requirement?
Yes, there is a structured process. So the moment we get into about any patient's requirement for any service, we have our assessment program, which is done. Assessment is done by our subject matter experts, are done by the patient field coordinators and followed by the clinical heads. In terms of condition assessment, like whether we are onboarding freshly from the home or from your hospital discharge case, we completely do a detailed assessment. And in that assessment, that's a form, and all the relevant details, medical conditions are captured and patient requirements are understood.
Okay. So thank you, Dr. Tarini. I think that was a good perspective. Dr. Jankhana Muj, you are from Ayurved Hospital, a transition care facility. How do we address patient engagement? Yes. Firstly, you have to educate us how a transition care facility is different from whatever we see on a daily basis. And then we look at what is the engagement issues, challenges that we have there.
Good afternoon, Dr. Rakesh and all dignitaries of QAI. It is an honor that Ayurveda Hospitals is contributing towards this initiative on World Safety Day. So coming to the point of transition care, let me just highlight few points that transition care management is a concept where it is the patients who are discharged from an active medical management. It could be from an ICU, it could be post-surgery. After the primary treatment that is being done, patient is fit to be discharged, but not to home. There are still underlying medical conditions, underlying clinical scenarios where patient needs to be cared in a controlled, supervised place like a hospital. And now Ayurveda is India's first of an integrative transition center of such a type where we are rendering services to patients who have been recovered from active stroke, active cancer management, children with various pediatric developmental delays, etc. So this is a kind of a transition care where patient is in need of a continuous medical care. So patient is shifted from the active primary treatment site to a step down care. This could be for residual symptoms, for quality of life, and for improving well-being. So with this, in this kind of a setup, it is important that there is a continuity of care, and there are various chances where there could be gaps in terms to safety. And mostly where I would like to say that it is because of safety not being a culture. Safety is a culture, it is beyond checklist. It is beyond just taking off things that are done. Entire team who is in transition care needs to be on same page, right from a competent and a competent care, medical care team to nursing team to everybody who is involved in patient's care. And it would be very interesting to note for transition care, National Institutes of Health, NIH, published a recent data where it showed that readmissions from transition care to a primary center were only because of suboptimal handoffs. So there is gap in communication. The receiving center, transition center, is not enough aware, cognizant of the facts of safety aspects that are there. So it is important that communication at all levels, right from the medical team to the patient and patient's family. We all have seen, all of us working in a healthcare system, that there are very marked sessions with the patient. We talk about the procedure, we talk about the side effects, we talk about estimates, insurance. But I feel as a physician and as an organization, Ayurveda, who is into safety, we should have safety sessions completely marked with this emphasis, talking about the procedure safety, talking about known and unknown safety aspects that are there with patients and family. And I think it is also important that right from conversation, it is important to bring safety to curriculum. Doctors should be learning about safety right in the medical school. It is later that when we start practicing, we start talking about safety. It is important that doctors are trained, resident doctors, nurses. Safety should become a part of their routine curriculum. And last point that I would like to share, because this has been a part of our training at Ayurveda, is that emulating interdisciplinary safety culture, like for example, aviation. We should be learning from aviation industry about bringing the core rigor of safety. And we should emulate this kind of continuous training where we can see that human factor. Every time we are on a flight, the steward or the crew reminds us of wearing a safety belt. Because there is continuous engagement with the passengers and the staff. Similarly, when we are in a hospital, our takeoff, our landing, every point should be made very smooth with the patient and the family. And when it comes to Ayurveda transition care, there are a lot of things there where there could be safety issues, right from diet, lifestyle, multidisciplinary medicines. So I think safety should be born as a culture in the entire transition care space that is there.
So, Dr. Zankhana, beautiful insights. I need to tell you, you need to tell us one more thing.
Yes, sir.
How do we elevate patient's voice in this?
So elevating patient voice comes from the aspect that patient is made aware of what he is going to undergo, right from the therapies to medicines, and then empowering him that he should be in direct contact, in conversation with a team in which he is being cared for. And once he is informed, once he is empowered to share about this, he should be having his own health insights. Oh, he may take some things for granted. Oh, this is a part of my thing that is happening. I think a lot of this non-reporting comes also from ignorance. It also comes from misleading information, giving the right education, allowing the patient to know that. I think that would be one, in my view, that patient will be empowered and elevated. And I would also like to share that Ayurveda millennia ago has listed 4 elements and of healthcare system: Vaidya, Rogi, Upasthata, and Aushad. Rogi is the patient and Upasthata is the caregiver. So all 4 elements are important in a healthcare.
Beautifully put. Thank you, Dr. Butch. Let us move on.
Thank you, sir.
And now we will touch a very interesting story, interesting side of patient engagement. We are all, Dr. Abhijit Paul, I am coming to you. Dr. Abhijit is the medical director of Practo at Bangalore. And he will be talking to us about telehealth. Now, kind courtesy Corona pandemic, we all have transitioned online. So we were, more offline and less online earlier. Now we are more online, less offline. And in that transition, even the patient consultation, which the Medical Council of India and later on NMC was not very comfortable with, but the COVID forced even the regulators to come with a guideline. Now we have formally structured guideline. There are telemedicine platforms available. And our interaction that is to happen in a 10 feet by 10 feet room between a doctor and a patient now happens on a 3-inch by 3-inch screen. So Dr. Abhijit Paul, you're going to tell us, how do we do the patient engagement on a platform like this?
Thank you, Dr. Verma, sir. And thanks QAI for organizing this wonderful summit. So it's a new journey for me also, because after spending almost 27 years in hardcore critical care and anesthesia, I decided to make the transition, move into digital health. And after a lot of thought process, I made that move. And the reason for moving into digital health was because slowly the digital health is catching up with a new name, which is called a phygital platform, which is digital merged with the physicality. And this entire concept of telehealth is very new. It's in a nascent phase. It's evolving, and it was extremely unregulated in market. If you see, there were so many platforms available, including ours, which is Practo. And of course, we started the journey way back in 2008, when we started off with software as a service and then moved into different product diversification portfolios. However, in recent years, we have seen, because of the non-regulation of this platform, people were using this platform and there were questions about data privacy, confidentiality issues, and so on and so forth. So I kind of got in along with the other players in Indian market. And we, on the first, we started devising, and we put up our first SRO, which is on the ethics and the clinical governance, what it should be across the platform. So there were certain criteria which we devised, and it was accepted by the Niti Aayog last year. So I was one of the major contributors in that whole platform. And then coming to Practo's journey on the telehealth platform, when we were in 2020, we did a data survey, 2020-21, that was in around that COVID time, when we saw almost 80% of the patients coming on telehealth platform were the first users of telehealth. And still almost 67% of the people coming on the telehealth platform wanted to still drop in person to visit a doctor. And we saw that almost 44% of the patients coming on telehealth platform were from T2 and T3 cities, the Tier 2 and Tier 3 cities. We saw patients who are less than 30 years of age comprised of 50% of the age group, 50% of the population, and female to male ratio was around 24 to 76. That means males, 76% males came on the platform and 24% came on the platform. And we saw obstetrics and gynecology, general practice, and dermat occupying 50% of the ailment. So this was in around just during the pre-COVID and para-COVID time. However, as the COVID waned off and when we came to more into a physical interaction, in the year 2022 and 23, what we saw was a growing pool of lifestyle diseases coming on the platform, like diabetes, hypertension, endocrine, mental and sexual health. And we also saw an upsurge usage of this digital health technology, devices like smartphones, wearable devices, apps, continuous glucose monitoring, and a huge surge of a lot of wellness program, which includes our own. We also developed one chronic care program, diabetic remission programs. We have the weight reduction program, blood pressure control, so on and so forth. So now when we saw our own platform of the diabetic remission program, which engaged the patient along with the device that they wore, the concept was basically it was a data-driven and a patient-driven input, wherein a very highly, very specific and very sensitive sensor was worn by the patient, and both the sensor would capture a data and patient would give their inputs, and both of them would get a synergy, and the input would be taken into a central pool, and it would be tailored to the patient's requirement of either the blood sugar or the diabetic control, and so on and so forth. But what we saw in our program, which was called the Transform program, which is a Practo's diabetic program, we could kind of transform 250 plus patients in 6 months with a weight reduction of almost 8 to 10 kilos weight reduction, weight to 10 kilos weight reduction in 6 months. We saw an average HbA1c of reduction of 1.5 in 6 months, of more than 250 patients. We saw 95% of the patient could reduce their medication doses. And we also saw almost 35% of the patient who could come down to zero medication. This is a complete Practo data. That is one thing. Then we also did a kind of study where patients were using both pill boxes versus app-based usage of technology. And in that we saw that many patients had given it to, it was of course gauged on a questionnaire which is called Wilcoxon's pre-post questionnaire, where many patients came up with positive responses that they could, that the app-based technology helped them to avoid medication mix-up, organized doses as per doctor's indication, would prevent incompatible dose mix-up, and also the timing of the medications were adhered to better. And coming to the clinical outcome, when the patient engaged themselves with the wearable device and with the smartphone application, there was some significant improvement in oxygen saturation in EICUs and in home care settings, better physical activity, blood pressure and weight control, blood sugar control, as I just mentioned in the Practo Transform program, and also better sticking to the healthier diet. And when we saw the p-values, they were significantly less than 0.05. Now, also, as I had mentioned, we had come into a platform where we where we were transforming into a phygital mode, which is a practo-care surgery. So we were booking patients on online surgery because during the COVID time, it was most of the doctors' chambers were shut down, and patients won't be able to meet up doctors. So we saw that the opportunities of number of surgeries across India, we did a major survey, and we found that there was scope of 1 lakh surgeries per month, which was possible on a tele platform through the booking. So we thought of a business opportunity also, and also to reach out to the patient. And then we devised a method of tele-triage of the surgical patient from Tier 2 and Tier 3 cities, wherein the patient would give in their inputs along with the family members through a video platform, and we could triage a patient and save their money, and it would prevent them from coming to the Tier 6 cities for operations if it's not required. In fact, I first time devised the first virtual pre-anesthetic check platform in Practo, wherein a patient could log into an anesthesiologist sitting far away and could kind of do even a Malampatti classification by opening his mouth. You can see and note down whether what is the degree of difficulty of intubation, things like that. So we devised a virtual pack which would, and if the patient is unfit, he doesn't need to travel all the way. And also we completely revamped our online portals of doctors, because we credentialed them so the patient could pick and choose those doctors who are credentialed and verified through their credentialing and degrees. We also privilege the doctors on the tele platform, so that a doctor who cannot say, who's very good in doing, say, laser proctology or say laparoscopic procedure, minimal access, things like that, we kind of privilege them for special procedure where the patient could pick and choose the doctor, go for a second opinion. They could also select their educational videos, downloadable material, and also in the chronic care, we have devised interactive quizzes for themselves for self-evaluation, so they can actually gauge, their progress. So that is one thing we devised, including physiotherapy and post-op rehabilitation videos were posted. So it helped the patient to make informed decision along with the family members in a home environment free of intimidation and feeling coerced. That is one thing. Of course, Practo, because we have also moved into small hospital, secondary hospital care now. We have just launched our first hospital in Bangalore, which is a 50-bedded unit in Electronic City. We are planning to fan out 20 more across geography. And it's very, very difficult to get a critical care physician in a small hospital because of the cost factor. Only yesterday, I was having a discussion with the Cloud9, one of the Cloud9 physician, Dr. Shashi, almost a 1 hour discussion of how to have safe tele-ICUs in these small settings, in this small hospital. Many walk-in patients who come with a little altered physiology, which might require low-dose inotrope, maybe a BiPAP support, we are unable to give because we don't have a on-ground critical care person. So tele-ICU involving, which is family-centric nowadays, and there are provisions of involving the on-ground healthcare workers with the family members to participate in decision-making. Video consenting is one thing which we are going to soon start in Practo hospitals, wherein the patient relatives would also be a part of decision-making in times of vital decision, like emergency intubation, putting in a central line, or doing an emergency tracheostomy. It also would help us to engage the relatives to kind of help us in taking measures and help us in giving them the prognosis and decision-making, including the end of life. And also there are studies which I was going through. There's a large meta-analysis study which came out from Norway, which says patient experience in telehealth in palliative and home care. Just now we had one speaker speak on the home care, and I can pass on that paper to this group. Anybody who wants to can kind of get in touch with me. So it sees almost 22 papers over 19 studies over 18 years. And it says that the easy and affordable health of telehealth, irrespective of the patient's condition, when it involves the family members through its technology, it improves the palliative care outcomes even at home. So as Dr. Verma, you rightly told that one of the things is to onboard the relatives along with the patient in a home care setting is very, very much valid. And with that, I rest my case, and I'm free to any questions if you have.
So Dr. Abhijit, we have, this is a webinar, so questions are not part of the game.
Sorry, sir.
We will move on and we will move forward. Next, we have Dr. Ashwini Okalkar and Mr. Sagar Sakam. Dr. Ashwini is the director of Ashwini Kidney and Dialysis Center at Nagpur, a renowned nephrologist and assessor in the QAI programs. Mr. Sagar is the business quality head of Apollo Dialysis Clinic. So we have these two stalwarts who will be talking to us about the need for active engagement of patients and their families in dialysis centers. Now, specifically to dialysis, let me come to Dr. Sagar first. Dr. Ashwini, I'll come to you.
Sure.
Let me come to Mr. Sagar first. How do you ensure active engagement of patients and families in dialysis? Dr. Ashwini, I will have a little more nuanced question to you.
Sure, sir.
So, Mr. Sagar, please.
Yes, a very namaste to everyone. So it's a very insightful sessions who's talked till now. So it's very eye-opening on the patient engagement in various departments and the specialties. So when it comes to the dialysis, so it's specifically nowadays, globally, the prevalence of kidney disease has been increasing from last 2 decades. So currently it is around 11 to 13% of patients are suffering with the renal failure across the globe. And it might be due to increased burden of diabetes or hypertension or over-the-counter medications. So the patient engagement on all these things, because even the family members also is unknown sometimes. Once the kidney disease progress to stage 5, they are unable to detect it because there is no symptoms till the patient comes under the second stage, third stage in most of the times. So it is very well important nowadays to educate the patients, especially those who are on the diabetes and hypertension, to how to prevent the progression of the kidney diseases, to take care by themselves. And especially then the patient engagement need to start from when the patient comes to the stage 5. And we thought that most of the patients must make a range of complex decisions, and the decision starts from choosing the dialysis modality, whether they have to go for hemodialysis or peritoneal dialysis or transplantation. So what they have to choose, and the specific choices concerning also plays a crucial role in their safety and even in the clinical outcomes, because the hemodialysis might not suggestible for few kinds of patients like pediatrics, whereas the peritoneal dialysis not suit for certain kind of patients who are obese or having some abdominal scares. So all these things we have to engage the patients and their family members, and we have to educate them they have to choose the right decision in going for the treatment in dialysis. And in another case, so most patients faces some challenges related to various intradialysis complications, electrolyte imbalances, and especially the complications related to vascular access, all those things. So hence promoting the patient engagement has been recognized as a crucial, not only in their safety, but also in improving their experiences and also the clinical outcomes, basically. Because the dialysis is not a life-saving treatment. It is like a life-sustaining treatment for them. And it is not like a one-time, because they have to undergo the dialysis on every alternate day in a week. So in addition to this, some decision-making processes, especially along with the healthcare team of dialysis center, the patients, their family members plays very crucial role, especially in making some psychosocial adjustments of the patients and learning to manage their self-care activities during this transition period. Because mostly these patients often experience the fear and ambivalence when they become aware of irreversible nature of the disease, like dialysis they have to undergo for lifelong. It is not like a one-time treatment where they will go undergo surgery and they can discharge to home. They can then it will be like a routine life, but it is not like that in dialysis. Okay, it's like a lifelong treatment they have to go. So for instance, that's why, and in the another third point, So when the patients who choose the peritoneal dialysis, especially, should they have to receive the training, how they have to perform by the self in their home. So execute all the exchange procedures by themselves. So there we have to train them very specifically on how it will impact, because if they won't follow the safety precautions, it will lead to some infections, and they can't further, again, they have to go further interventions. Whereas come to hemodialysis, especially the vascular access, which is their lifeline for them. Actually, the vascular access is lifeline for them. Once the lifeline is won't work out, they have got some complications, then their life will be messed up. So we need to, once the patient comes for the dialysis treatment, from the day one, we have to engage both the parties, both the patients and their family members. We have to educate them, and we have to explain them what might be the consequences the patients might get in the future, because on the long run, the patients may get some various complications during dialysis, like hepatitis. They may prone to hepatitis, and they may prone to cardiovascular diseases on long term when they are on dialysis. So we have to educate them clearly how to take care by themselves, not only in the dialysis centers, even in their homes, because it will influence a lot. Even the clinical outcomes majorly depends upon how they are practicing the self-care and self-safety at the homes. And so this is the major practices. Even from the COVID time onwards, it is most important that even comes to their safety, the hand hygiene practices, and the because of their low immunity, the dialysis patients are more prone for various multi-organ failures and other diseases. So we have to engage them from day one onwards on each and every aspect, from vaccination to regular health checkups, for the better quality of life to lead.
So Mr. Sagar, thank you. I think you have covered a lot of aspects, but when it comes to dialysis, I think we should give the last word to the nephrologist.
Yes.
So, Madam, Dr. Ashwini, I need to ask you that it is fine. I mean, dialysis is something that, whether by default or by circumstances, the patients figure out that they have to live with.
Yes.
But what are the strategies that we can have for improving the engagement?
So first of all, yeah.
Yes, please.
Thank you for inviting me as a panelist here. Thank you to Team QAI. I've understood your question, whereby how do we improve patient engagement so that there is reduction of risk and there is improvement of patient safety in the dialysis units. Is that right?
Yes.
Yes. So there are Deming's famous quote is that quality is everyone's responsibility. And in this everyone, I would like to include the patient and the caregivers and the relatives. So let us not forget that it's not just healthcare staff, but patients themselves, like Mr. Sagar said, who are coming lifelong, who need to be involved and engaged. So there are many studies that have been done by American Nephrology Nurses Association or American Society of Nephrology. There is a choice study. And all these have pointed to a few particular concerns. One is patient falls, which has been mentioned earlier also. Medication errors. But by medication errors, Dr. Saravanan had mentioned that we should do medication reconciliation and other things. But not only that, in dialysis, it also means the dialysis prescription, the preparation of the dialyzer membranes, the preparation of the machines also sometimes. Then there is loss of infection control protocols to be followed and lack of communication. These are many concerns which are to be addressed in a unit. So how do we ensure that the patient is involved in all of this? So there has been a model which is described in American Journal of Kidney Diseases. And there are 4 aspects. First is patient education, like Mr. Sagar again mentioned, patient communication, patient participation, and last and not the least is patient empowerment. Now, how do we go about patient education? So there are things like one-to-one conversations, but the nephrologists usually are short of time. There is a dearth of time for them. So it is important to involve our healthcare staff. And recently what we have done is started involving the older patients in the counseling of newer patients. That works wonders because they have a sense of confidence building up in them that, okay, if this patient can do it, why not I? If this patient already knows so much, why not I? So patient education is very important. Once they are educated, their knowledge and skills are improved, then they can take part in the communication and be confident about voicing their concerns to the healthcare staff. Joint Commission, one study has been done in which only about 20% of the patients on dialysis felt little bit confident about telling the healthcare staff their concerns. So imagine 80% are just quiet and not saying anything. And even the 20% are only slightly confident, not very confident either. This needs to change. So what we need to encourage is dialogues. Therapeutic communication is something which is goal and purpose driven. It's not just social communication like, how are you feeling today? It's about like, what did you have any symptoms the other night? Are you okay between the two dialysis periods, intradialytic period, and things like that? They need to be educated, and therefore then they will communicate better. So what is the other education that's important? They must know about adequacy of dialysis and what the machine is being set up, what the dialyzer does, what is KT/V, what is URR. These are things that even patients should know. Why only the technicians? Okay. The third aspect is patient participation. So we have found very often that when you involve the patients in their own medication reconciliation, for example, we ask them to bring their boxes to the unit. So once the boxes and the prescription are matched, we often find, oh, so even the healthcare staff, even the patient's relatives, even the patient himself, they are all involved and engaged in that activity. So patient participation works wonders, not only with that, with their diet protocols, with the fluid that they consume. In all ways and manners, if you engage patients in participative activities, it works better in the long run because then they are more responsible for their own healthcare. We don't want the responsibility only to be on the healthcare providers or the doctors and nurses. Even the patients and the caregivers need to be responsible for this. And last but not the least is the patient advocacy. Okay, so it's patient advocacy, which is very important. The older patients which are there for long term on dialysis, like 16 years on dialysis, 20 years on dialysis, it's found that they are very adept at voicing their concerns in a very firm and assertive manner. And there is even a program in USA which is known as the Speak Up program for dialysis patients. They are encouraged to speak up and say, okay, do you think this infection protocol is not being followed here? They will gently remind the technical staff. Because we need to understand they are on dialysis for 20 years, but the staff which is attending them may be just a newly appointed technical staff, or it may be somebody who is only 2 years experienced in this field. Compared to 20 years of the patient experience, 2 years is not much. So it is nice that the patients are encouraged to do all these activities, but this requires a lot of openness on the part of the unit, on the part of the owners. And there is where all the quality initiative begins, where the management, the top management's commitment has to be seen in all of these endeavors. And I'm sure with this, one day will come where we will be happily working together and being responsible for healthcare together. That's it.
So, Dr. Ashwini, can I just pick your...
Hello? Rema, is my screen? Sir?
Can you hear us?
Yes.
So let me pick your brain a little more.
Sure.
Now, see, we all want our patients to be aware. All of us are trying to do, okay, educate the patient, make him aware, etc.
Yes.
However, when it comes to the patient, as a patient, what is my problem? My problem is that I don't know what question to ask.
Fine.
So the generic leaflet or a pamphlet or a TV display or a standee or 5 minutes of conversation with somebody, it doesn't tell me what questions I should ask. Yes. So is there a good case for a dialysis program to standardize certain questions directed towards ensuring a patient engagement?
Definitely, there is. Yes.
Can we have a set of questions, some hard-hitting questions where, like you said, the patient challenging the technician, do you think this is good enough? Mm-hmm. So if we forward, tell the patient that we expect you to ask this question. I think that will force the engagement. Why I am saying is because all our soft approaches for last 2 decades are only soft. We are not reaching anywhere. I think it's a good case that we must now stop educating patients and start giving them questions.
Yes.
That this is the question you must ask.
Yes.
And these are the possible answers. You should get one of the answers. You can't say that the question is such an open-ended that it doesn't have a clear answer. So I think that will be, so what is your view on this?
So there are very good initiatives in this also. Recently, I've come across a kidney health coach course, which is free online at just about 4 hours in duration, which even patients can undergo. It's not just for healthcare workers. This is by the American Association of Kidney Patients. And there is a similar program, which is by the kidney, I think a kidney foundation it is, I forget which one, in which an entire course module of 13 modules is there. Even patients can undergo that, and you ask them questions as a healthcare worker. What about anemia? Do you know what erythropoietin does? Are you aware how much your hemoglobin is? Do you know what hemoglobin is in the first place? What is its role? So there are online courses like that. And
so I think,
yeah.
So I think to kind of in the interest of time,
yes,
I think we should the QAI and Dr. Ashwini, we should collaborate more and let us come out with a program under the banner of QAI as a health coach program for dialysis, which could become an adjunct to whatever work is being done. I think that's a beautiful insight, and that also opens up a few more windows in our minds and possibly some doors in future. So to make a difference somewhere. Okay, let me move on. Dr. Ashwini, thank you very much. Mr. Sagar, thank you very much.
Sir, before we move ahead, Dr. Ashwini has shared something with us. So can we share that? It's a video.
You want to show it now?
Yes, sir.
Okay, please. Please show that video.
So just a minute.
Yeah, good morning, Dr. Rakesh. As Dr. Ashwini said, there is like NKF, where NKF is National Kidney Foundation, where they encourage the patients to come do their priming, everything, even picking up their fitla also they give a training, and they do themselves because that involves them into the treatment of hemodialysis, where they get a good confidence and they do a quality of life.
जब इमरजेंसी होती है तब आपको डर लगता होगा, तब फिर आपसे बात कैसे करते हैं स्टाफ वगैरह सब?
हाँ, बात करते हैं हम पूरे स्टाफ अच्छे से बातें करते हैं और सब काम लग जाते हैं बराबर और ऑक्सीजन की तरफ जाते हैं और
उनके काम सही सलामत करते हैं। लेकिन आपसे कोई बात करते हैं क्या
तब बात करते हैं ना, घबराना मत, ऐसे हमको हिम्मत देते हैं, हम है ना सब लोग ऐसे बोलते हैं हिम्मत से।
जानकारी देते हैं क्या कि क्या हो रहा है, कॉम्प्लिकेशन?
नहीं, थोड़ा वो बोलता है कि फेफड़ों में पानी भरा इस वजह से होता है ऐसा, घबराना मत, हम लोग है सब।
Sir, you are muted.
You are on mute.
So Dr. Ashwini, thank you very much for that insight. And let us move on now. And now we have Mr. Arka Prabha Bhattacharya and Dr. Manjinder Bhatti. Mr. Bhattacharya is the Senior Manager Quality and Accreditation Coordinator at Tirathram Hospital in New Delhi. He is also the NABH Assessor QA assessor and also has experience in NABH for some time. Dr. Manjidhar Bhatti is the MS and the MS at Metro MAS Heart Care and Multi-Speciality Hospital at Faridabad. So we will ask the two gentlemen, what is it that the hospital can do to get involved in raising awareness and by to empower the families and the patient? What is it that we can do to elevate the voice of patients? So Mr. Alka Prabha, please, can I ask you to share your views as an assessor when we see the hospital doing something? Is it that it is helping elevate the voice of the patient?
Sir, am I audible, sir?
Yes, you are.
Okay. Thank you so much, sir. Thank you, QI, for onboarding me for this program. Sir, let's talk from the assessment point of view because then Dr. Bharti can talk about the hospital point of view. To think from the assessment point of view, when you go for an assessor, see, I think we have already discussed the patient safety is not a practice, it's a culture. So as an assessor, we need to understand if the culture is prevalent in the hospital, it just remaining as it documents. So in the assessment, usually, personally, if I ask me, then I really don't see the document first. I try to interact with the patient first. So I choose a patient who has recently admitted, maybe they have admitted for a couple of days, or the patient is going to discharge maybe tomorrow or maybe on the day of assessment. So if you talk with them, a very informal discussion kind of things, you'll get to know what they have been informed by the hospital or the clinical care staff when they're admitted. See, when the patient comes first time in a hospital is a very new environment for them. It's very important for the nursing staff or maybe the other operation staff. They intimate the patient about the hospital environment, some basic information maybe from the safety point of view. The patient lying on the bed, let them know where is the nursing call bell. Let them know if they go to a washroom, there is an emergency call bell also available. If they're uncomfortable, they can just buzz that call bell. But so many times, even in my hospital, sometimes other hospital even go for assessment, patients are not adequately intimated about the safety aspect. Let's come to the next step. Next, the first thing that we do, that is a patient assessment. The assessment done by a doctor, assessment done by a nurse. So in assessment, we just bombarded with the informations to the patients. We really sometimes really don't ask anything about their lifestyle, anything about their food habits, what drugs they are taking. I think one of our speakers talks about drug reconciliations. See, drug reconciliations, there any allergy of drugs, any previous history of drug allergy is not possible unless you ask the patients. So very important that we communicate as a healthcare professionals, we should communicate with the patients, not only giving the information. The communication is the key. Unless we communicate with the patients, we cannot engage them. Because sometimes they're very scared, they're very apprehensive to tell anything. And this hospital, maybe some patient, they come first time they are admitted in a hospital, they don't know how the hospital functions. So it's our responsibility to make them comfortable and possible to know as much as possible of their lifestyle, their food habits, their daily medications. So accordingly, we can just fix that things. I have an example for this. Sometimes some months back, we had an assessment, and when I just entered the hospital in the ward, there's a patient lying and the blood transfusion was going on. I just asked the attendant, have the consent has been taken? There's no consent taken. And the same patient had a blood transfusion reaction in a different hospital some months back, and the staff is not aware of the fact. It's a prime safety issue. The staff is not aware the patient had a previous blood transfusion reaction. So it was not possible because they never interact with the patient before giving the bloods. So that much of interaction is very important. So maybe after 2-3 days when the patient is in the hospital, whatever the information that you have shared with the patient at the day of admissions or maybe on the same day, let's repeat that information because they are very much preoccupied with that disease process. and they don't know what is called patient safety. So it's very important to teach them almost every day a small piece of information about safety. So they can take that information in their memory, and when they're leaving the hospital, even they can practice those things at their home. Let's coming to the another episodes of the patients in the hospital, that is discharge. To my opinion, even I see in my hospital, even other hospital I've experienced, that discharge is a very critical area or critical touch point for the patients, because the last time the patient is with you, and you can give as much as information to the patient so he can carry on that information, that safety aspect at home. For example, you are giving some advice, giving some medication the time of discharge. Patient doesn't know is there what food has to be taken, what food not has to be taken, what the other medication he cannot take. Suppose a patient living with a Foley's catheter, you have to give adequate information how the catheter care has been taken at home when they're supposed to come back to the hospital to remove the catheter. I have seen patients, they are not at all informed and they come to the hospital with an infections. So if you guide them, if you guide them properly, they might take some of care at home. So from the hospital point of view, from the assessment point of view, so it's very important in the assessment also. We should interact the patient first, try to understand what information they have given, they have taken from the hospital and the clinical care staff. Next, let's also have an understanding from the clinical care staff, I mean the doctors and nursing. Are they oriented to the patient safety practices of the hospital? They have the basic understanding of the patient safety practices. Are there any session or the IPSG goals? Are there any session on the other safety aspect of the patient? If they're aware, then I think the last thing in the assessment that you can see the documents, whatever they have said, whatever they have done has been documented. Like there are Morse scale, vulnerability scale, drug allergy, everything. If they are not aware, is not communicated to the patients, then the documentation doesn't make any sense. So first interaction with the patient, let's communicate, let's engage, then document. So I think it's a very holistic approach, interaction with the patients and communication. I think the key for the patient engagement. So I think that is from my side. Sir, you're
Thank you, Mr. Prabha. Thank you very much. Good insights. So let me ask Dr. Manjinder Bhatti. Dr. Manjinder, you are the medical superintendent of a big hospital. How does your hospital implement patient awareness and empowerment of the patients and families?
At the outset, thanks to Dr. Verma and the QI team for giving me an invite for this session. I was hearing all the speakers very patiently, and a lot of insight has come in. I'm audible, sir?
Yes, please. Yes, you are.
Okay, sir. So this year's the basic idea was for engaging patient for the patient safety, and as you said, it has been going on for almost 2 decades now. In 2005, in London Declaration, this thing came up of empowering patient, engaging patient, and encouraging them to participate in their own healthcare. Talking about my own institute, sir, Metro Group of Hospital has around 16 hospitals, and our chairman, Padam Bhushan, Dr. Purushottam Lal has, whenever we interact with him, this only thing he tells to us is patient first. That is the guru mantra of all his success, patient first. Now, how do we need to implement it? That is the major question. We talk a lot about engagements. We talk a lot about it should be done, but actually on ground, how it need to be implemented. So the message has to come out and clear from the top management. It has to percolate from the top management that the patient is first for us, and there we need to empower our own staff, healthcare providers who are dealing with patients and their relatives or their attendants, so that they are well versed with that particular area in which they are working, so that they can further educate the end care patient and their attendant. For example, in terms of there was some, that is exactly right. There are a lot of hesitations. Patients attendant don't know what to ask for it. So what we do is a very wonderful thing most of the hospital nowadays are doing, is that we interact, make the old patient interact with the new patient. For example, a TKR successfully completion of 100 TKR, kidney knee replacement patients, we call them the successfully treated patients, and the patients who are potential to go for TKR. We make have a discussions with them. We have an awareness sessions with them, and once they may not hesitate to talk to a healthcare provider, but when they see a live example of a patient who has been successfully treated and is leading a quality life post that treatment, and whatever worries they have, they can directly interact with them. Then second aspect is the University of Malay Medical Center in Malaysia. They conducted a study on the patient fall in hospital. And they found that the potential cause of fall was like language barrier, lack of education among the healthcare providers, inadequate knowledge of healthcare providers themselves about the assisted devices, and obviously the compliance with the patient. How can we improve that compliance? Very clearly, we first need to decrease this barrier, make our own staff aware of if I give you a simple example, an orthopedic patient is being made mobile with that walker. Now that walker, the clear instructions need to be given that the walker need to be put up to move forward. But most of the time we see the patient is, sliding that walker to move. And that is the potential one cause of fall. So these kind of things, practically we need to make the patient aware, their families aware about. Then another example, if I give you, there is an American Journal of Medicine Orthopedics. They have done a study and they gave us a data that on the patients, around 100 plus patients were, counseled about their bone status. They were given written materials about how to go about for their bone health, and they were convinced to go for a bone densitometry test. And post the bone densitometry test, they were again, counseled how to take care at home, because it was a major chunk of this program was to be conducted at home. So the patient who underwent these counseling sessions, who went with the literature, who went with the bone marrow densitometry test and was explained the importance of it. So there was a compliance of around 72%. And the rest which did not comply, the reason found out was the patient misunderstood the instructions. Then there were complex language or complex technical jargons were used while explaining it to them. And some involved major lifestyle changes, which, you cannot expect them to be following in a single session or a single setting. You cannot convince somebody who's following a lifestyle for 20 years. In a single session, you cannot expect them to be, following the lifestyle you want them to be. So these are the few things, which we have to be there. Apart from them, nowadays there is the new technology has come up. A lot of chatbots have come up. So there is a chatbox by the name of Florence, which take care of the mental and the mental wellness of the patient. And other chatbots are also there. You know how these chatbots help? They set up the questions query of the nowadays tech-savvy patients who are in the age group of 20 to 40, who are using most of the these technologies. A classical example was that this chat box interacts with the patient, take down their basic information, demographic information, and their symptoms. So by the time that patient reaches the triage area, the doctor over there is well aware of the basic things that he needs to do for the triaging. That saves the time, that saves the cost, and that helps us to promptly initiate the treatment so that we can have a better compliance and outcomes. At the end of the day, the entire scenario of engaging the patient is to have more compliance from them and to improve the outcomes and increase the patient satisfaction. Thank you, sir.
So, Dr. Manjinder, thank you very much. I think good insights. And with that, we have come to the last session for the day. Madam Nadira Chaturvedi is here with us. Madam, can you unmute and also put on your video. Yes, ma'am. So good afternoon, ma'am. And she's the, she's associated with Patients for Patient Safety Foundation. It's an organization that is, it's a non-government organization based in Delhi, works towards patient safety. And she's truly that patient for patient safety. So it's like nobody has the better perspective than what she's got. So let's hear from us. And so she will be talking about how do we engage patients. Now, patient engagement is something where all of us can claim to know some parts of it. There are enough technological interventions available. Social media has made our life, whether good or bad or miserable, that we can decide for ourselves. But it allows us to engage in a certain manner. So let us hear from her and her experience, and also as part of Patient for Patient Safety Foundation India, because this happens to be the only organization that at present looks at the patient's voice. Ma'am, please.
Thank you, everybody, and thank you, Dr. Rakesh, QI team, Dr. Rana. It's a privilege to be here and to hear so many wonderful things. So much knowledge has come in, so many insights have come in. Yes, as you rightly said, we are looking at patients' perspective. Our name is Patients for Patient Safety Foundation. All the wonderful talks that I heard from Dr. Usha or Dr. Ulakar and everybody has given lots of knowledge. But there is one thing that is common among all of these things. You all are relent, and whatever little exposure you've had in the last 2.5 years, is everybody is working sincerely, hard, technology, chat box, AI, everything. But you all are working for the patient. I heard only 2 people who are working with the patient. I'm differentiating the 2 words. For the patient, every single healthcare worker does. With the patient, I think it's the NGOs or the palliative care teams or the support groups who are getting into this, including the dialysis teams. So when you distinguish these 2 words, one main facet I would like to say is, you all are disease-centric. Are you person-centric? Patient-centricity is being ironed to the bone. I'm not even talking about patient-centric. But there is a bigger thing there. There's a disease and the person with the disease. So when we come in, we are looking at the person and not only the disease. We're coming in from the patient's perspective. And the third dimension I want to draw is, you are all telling us what to do. Nobody tells us why we need to do it. So our work, we have inverted this whole prism, inverted this whole jacket inside out. And since everyone is doing so much, I don't think we need to even dream of repeating what you're doing. I will only ask for inputs of what you're doing, the insights, the issues, the problems that healthcare people have vis-a-vis patients. We in the foundation are doing what we can do to improve the healthcare. What we as people, as caregivers, as families, as communities, and as patients can contribute in this journey, making it a partnership and not just surrendering to you all. I mean, God syndrome is there, particularly in India. We come and we say, we have reached the right place and Bhagwan will take care of everything else. Now, God helps those who help themselves. That is my mother's favorite adage. And she made us work hard for our own health, for our own safety. So what we're doing is creating information, since you don't like the word education, okay, creating forums and modules and methods to engage people, physical also, technology also. We have a website, we are pushing it out. There's a push strategy, there's a pull strategy, and we're creating it into both text forms as well as graphical forms. Some of them I can show you. We're converting it into regional languages, and we're showing people what they can do, not just what somebody else can do for them. That is our main focus. Having said that, there are 2 sides to a coin. I don't know what is the meaning of a fall. I don't know what is the meaning of macular degeneration. I don't know what's the meaning of a G bag. I only know that the food goes through a pipe, all right? And that to me is a G bag, a gravity bag, a Riles tube, whatever you may call it. You tell me how to mark it, I can understand that. I don't know when to set an alarm and I don't know when to escalate. I heard these 2 words, which are really nice. Okay, so if you teach us, we will teach everybody else. We can reach a certain number of people, but there are massive numbers in India, and we want the healthcare people to use our knowledge in your TV screens, in your forums, in your auditoriums, in your waiting areas, in your idle places, and help us to spread this word so that we do it. I'll give an example. I mean, I'm just going to show you, we are talking about falls right now, right? Lots of work about falls. I don't know whether can you see the screen now? So we created this visual literacy, all right? How a person can help reduce falls in the hospital, how a person can reduce falls when he goes home. It was nice to listen. What is our own responsibility? Do we have something to share? Yeah, I don't know whether you can see that. So we are trying to create material that a person themselves can offer, do, and help the doctor, help the nurse, etc. So that is where we are coming from. And yeah, thank you for saying that. So for example, I wanted to share this particular one. I don't know whether it's visible. Yeah, I think it is now, right? So, and we got it, I'm deliberately showing it to you in Hindi because we do have, of course, we created it in English, we all speak English, but the Hindi version and graphical. What do you do in the bathroom? What do you do in the steps? What do you do in the common areas? What do you do in your bedroom? So things like that, which are easy, simple, etc. In fact, there was a very important one that we did. Our first assignment was explaining to the people about their rights and responsibilities. I had the privilege of interacting with a bunch of patients on rights and responsibilities. It was a Hindi speaking audience. I'm just going to give you one quick example. And one of the tom-tomming thing was, take your medical records and show it to the doctor. I threw the paper and I said, show me your medical records. Every single patient took out a pitara, a box, a bag, a thela, a packet, a newspaper envelope, and they were all over the place, all over the place. And then I said, do you know what you're doing? That what will the doctor do? He'll say, next, please. He has no time to compile it. It was your job to put it in order. It was your job to put it in chronology. It was your job to get all the reports done. So when they saw it practically, this was an eye-opener for them that yes, they can participate, they can contribute, and that is where we are coming from, and that is where our work goes. But it is from the patient's perspective what we do not know. So something nice that we heard was what questions to ask. Should we ask? How do we enable them? It is the healthcare people who know the patients, who interact with them. Maybe we need to create rooms, forums, spaces, and structures where we encourage interaction, counseling, and asking questions, and not just giving information. So that is that's where I'm coming from. And that is a request from all the wonderful people here to do and to share and to teach us and promise we will do our best, because connecting us is going to be it's going to be a challenge, but we are there to give you and we'll also give you the issues that we face. And if you listen to us, I think we'll all benefit far, far more. Trust me, we're doing it to help you. It's going to be your gain, not just our gain. It's going to be a sincere customer. Okay, I use the wrong word. A loyal patient who will come back to you, who will give you referrals, so who will keep the records in order. So if a nurse thinks she's wasting her time in teaching somebody how to give an injection, how to give a Ryle's tube, why hand wash is better. After hand washing, don't wipe it with your sari or your apron, because that's what we all do in the house, or the kitchen cloth, and all your washing is gone to finish in spite of the best of soap. It will be lesser coming back. Your costs will reduce, your profits will increase, your brand will improve. And that's where Patient Advisory Council, which is a premature discussion right now. But yes, we're coming up with that. And we want a seat on the table. We want a partnership, not just a dictatorship, not just something else. That's where we are. So thank you for listening. And I heard many doctors here, and I would really, really appreciate getting inputs and collaborating with all of you so that we can improve the inputs that we are teaching our patients. These were just some examples. We've got lots more on our website. Thank you, Doctor. And I think you have been the best of the all, Dr. Rakesh, for the teasing questions, the provocative agendas that you had. And I think that worked very well for all of us. Thank you.
In this, thank you, ma'am. Very nice hearing from you. And after, of course, seeing you on face to face after a little break. Yeah. I think I have come to a conclusion in many things in what I do, not only for the purpose of this particular webinar, is that sometimes knowing a question is more important than knowing the answer. Because if you have a question that is the question to ask, that makes a lot of difference. That will make all the difference. So I think we have had a very nice range of discussions today. We have looked at perspectives which otherwise we were not privy to. And we have discovered a few new things today. I think it will be for us to carry the torch forward, to carry the message forward. And finally, we will have to ensure that, like Madam Nadira said, like we don't tell the patient. We communicate with. So patient is with us on the same table, at the same level, and not differently. This is what I think will make a lot of difference. Sometimes as a doctor, when I am a patient, it's almost a similar story. Only thing is that the view changes. So you get to see the same thing that you've been doing wrong all along. So therefore, it's important that we understand these nuances. And some of these speakers, like Dr. Ashwini's, very good work is being done. I think there is also a need for large, rather for scaling it up, so that we are able to reach out to more people. Thank you, everyone. Thank you, every speaker. I think you've added tremendous value to our discussion today, and we have enriched in this. We have exceeded our time by 20 minutes or 25 minutes possibly, but I thought it's a good idea. If something good is being talked, I think the time should not come in our way. So with that, thank you very much. Thank you, QAI team. Remaji, Ms. Sakshi, you've done a fantastic job. And we have had a session that really made difference, at least to my understanding. I'm sure it has helped all of us as well. Could we request the QAI team to at least summarize the points that we've discussed and maybe share with all of us? So thank you very much. And great seeing all of you. Many of you I'm meeting again after a break. Very nice. So thank you very much and all the best. Let's start working on this.
Sir, on behalf of panelists, thank you very much. We enjoyed the session. At least I did. The entire session.
Thank you, Dr.
I gained a lot of insight, and my task list has just doubled and tripled the work that has to be done.
Thank you. So, Ms. Sakshi, we could close.
Thank you, Dr. Rakesh.
Thank you so much, sir. Thank you so much.
Dr. Rakesh. Very well moderated. Thank you, everybody. Thank you so much.
Thank you. Yes, Ms. Sakshi, you could formally close so that we can.
Yes, sir. Thank you so much, everyone. Thank you for joining.
Okay, all the best.